So I am Lisa VanHoose. I am a PT at the University of Kansas, and my laboratory's name has actually changed because we have moved it from being just physical therapy to actually a multidisciplinary laboratory, and so we thought that the name should reflect that. And then I also serve as the co-director of a multidisciplinary clinic that has both physical therapy, occupational therapy, and psychologists that are located in this clinic. And our model is a little different than your traditional rehab model. Every patient that we see in this clinic, we ask them to undergo cognitive training and testing. And the purpose being is that it is very difficult to give someone instructions if you don't understand how they learn, or if you haven't identified whether or not if they have chemo brain. And so it has been quite beneficial to have the psychologist in our clinic. The other thing that I do, I am the mother of four, and I sound like I'm very loud, is I serve as the president of the oncology section for the American Physical Therapy Association. So I thank you so much for allowing me to be here and to come late. I actually was at a Komen conference yesterday and then flew in late last night. So here are my disclosures, and the only one that I really have other than I work at the University of Kansas, so if you are from Missouri, I am sorry. But I have a research grant through LymphoPress. I'm looking at pneumatic compression for bariatric-related lymphedema, and they have provided financial support for that. So the objectives were listed in your program, and as you are aware, the definition of cancer survivor has expanded to, at the time of diagnosis, you are now a survivor. That's the NCN definition. And so therefore, there are multiple experiences out there, multiple trajectories of what happens along someone's journey. And what has been really nice over the last 3 decades is just this increase that we are seeing in survivorship. And so the numbers that are listed here are shown for all cancer types, and this is from the American Cancer Society. And so you can see the growth. And so underneath there is that question of why is that significant? Well, because we know that once you hit that 5-year survival rate or relative survival rate, that your risk of dying drops, and that also your life expectancy starts to increase. So we have done a really good job of having people survive, but now we need to do more on having them survive with a good quality of life, because that is what we are hearing the patients in our clinic say, is that they feel guilty sometimes because you have done such a beautiful job of helping them see their next birthday, but they're like, how do I tell them that my next birthday kind of sucks because I'm tired and I'm in pain and my feet burn? But they're like, they feel really bad about telling you that. So they come into our clinic and they tell us like it's a secret. And we're like, okay, we'll hold the secret with you. So we'll keep telling them that everything's great. But there is a lot of impairments going on behind the scene. And so these are the numbers that are actually posted on the American Cancer Society's website, and they are related to breast cancer and from the Sears database. Now this is with the old staging, so I believe 1B is still in the 2 stage in this particular graph. But you can see how for breast cancers, from stages 0 to 3, the numbers are great. They're really, really good. But there's a lot still left to be done with just what are they left with afterward. And so typically these are the side effects we talk about with patients. You know, chemotherapy toxicity, so you might have neuropathy. If there is late effects of radiation, and then also there are things that happen to the skin and declines in range of motion and function related to surgery. And that has nothing to do with surgical failure. It's just that's how the body heals sometimes. And so these are those common conversations we have with patients. Now, the next step, though, is that what the literature is showing is we talk about this new normal, and you're going to be able to get back to where you're at. But especially in the U.S., we love to work. That is how we define ourselves. The first thing you ask someone is, hey, what's your name? And what do you do? But for a lot of our patients, they don't get to return back to work. And for those who do, what the literature shows is that they are returning back to work at about 50% of productivity. And that is a huge slam to your psyche. Think if you were a nurse or a physician and you could only go back and maybe perform at 50%, and your peers are around you going, I thought you were okay. And so it just keeps reminding you of what you've gone through and just how you may not be at the same levels of others. The other thing is the burden on the family. There was a lot of conversation in this last session about you need to engage the family and have the family be active participants, but there is. Most of these families are working. Most of these families have other care members, other family members that are also going through health conditions. So there is a lot of responsibility on the family, and we're expecting them to absorb a lot of information. And so we have found that rehab professionals can be really good resources for the family in regards to training them, also talking about their wellness. Because if they're not well, they can't take care of your patients. And so in the PT world, we typically talk about 4 major systems, okay? And so for this particular talk, I'm going to focus in on those 4, but just know we're all aware that the treatment of cancer can affect all systems, but these are the 4 that are normally focused on in PT. So cardiopulmonary, and so the impairments are listed here. So decreases in lung function, and then what are going to be those clinical signs? What are going to be some of the things your patients are going to come to you and say that they're having issues with? And it may not be the fact that I'm short of breath. It may be I'm only short of breath when I'm trying to get to a football game or when I'm trying to go up and down the stairs at work. So you have to get really good at asking lots of questions and not just yes or no questions. You got to kind of ask that open-ended question and have the time to wait for an answer. The other thing is changes in the skin. Lymphedema, I am a PT who is LANA National Certified in Lymphedema. I'm so tired of hearing about lymphedema, okay? And here's my reason why. It's because the patients, when they think of cancer rehabilitation, all they think of is lymphedema. And they think I can only come and see a therapist if my arm is swollen. Most of the time, your arm being swollen is only one issue you're dealing with. They normally have fatigue, they've normally got neuropathy, sometimes they've got pelvic floor issues, lots of times they're weak, but they are so focused on their lymphedema, and I just got to take care of my lymphedema. And I'm like, I need you to see the big picture, because your lymphedema is going to be worse if you can't walk. Your lymphedema is going to be worse if you have neuropathy, because what happens with the neuropathy is that the lack of sensation actually causes a disruption of the neuromuscular junction, and so then they have muscle weakness. If you don't have if you don't have muscle strength, then your lymphatic system is dependent a lot of times on active contractions. So I'm like, your lymphedema is just one thing. So I get tired of hearing about lymphedema. All right. The other thing is tissue fibrosis. And this is a big one, especially for women of color. There is, particularly in the Latino and Hispanic communities, and I apologize for some of the generalizations, but in the Kansas City area, what we are seeing is that those women are very cautious to actually do scar massage, to mobilize their tissue. And so we have to have a lot of conversation with them about it's okay for you to touch that area. It's all right for you to look in the mirror at it. Because in that culture, there is such a strong focus on body image that I think it affects them when they have that change in their appearance. And so you have to be prepared to have that conversation with them. And then for African American women, depending on whatever their skin texture is, some of them do have some increased collagen presentation and those things where within 2 or 3 weeks after surgery, sometimes we are putting a compression, like a chip pad or something in their bra to kind of help with their skin healing. So there are some extra things that it's not just walking a patient, dragging them out of bed. PT does more than that. OT does more than that now. And then underneath the musculoskeletal, those are the things that you're familiar with, most PTs doing. So we can assist with weight management. And it's not just telling your patients to get to a size 4 or size 6. That's not the most important thing. There's beautiful work from Steve Blair talking about you can be fat and fit, which there are some of you who are like, don't say that. Which we do tell them. Thank you very much. We do tell them that, you know what, we want you to get to this target BMI, but really our primary goal for you right now is just to exercise, just to do 150 minutes of activity a week. We're not going to focus on your weight. We just want you to do something. And then we will have our psychologists work with them on their coping and their lifestyle behaviors. But we try to move away from just that BMI focus. Fatigue is a big thing we work on in our clinic. We talk a lot about how to condition yourself out of fatigue, very similar to how you would condition a patient with intermittent claudication. We do the same strategies. But it is not right for us to tell people that they're reporting fatigue levels of 5 out of 6, 5 to 6 out of 10, and we're like, you're doing okay. That's not right. That's not right. Because a 5 out of 6 in the morning is an 8 out of 10 in the evening. And so they are dragging themselves into bed, trying to go to family functions, trying to be normal. And so there are things that can be done from a therapeutic standpoint to address those. And then there are various neurological things that appear that can also be treated with therapy. And so this is actually an article that is posted on Medscape, but the actual reference article is located in the Cancer Journal for Clinicians. And so what I want you to hone in on is this little area here that talks about 1 in 4 cancer survivors report that they have poor health. And 1 in 10 report that they have poor mental health. Now, the sad thing that was pointed out in this review is only 30% are receiving services. And it's not just because we as providers aren't listening. Sometimes it's because we just didn't ask the right questions. Sometimes it takes a little prodding to get to the answers. I will be honest. There are times I see patients 4 or 5 times before I really understand what all their impairments are, because they're a little cautious about having that conversation. But the other thing that was pointed out in this review article was that 63% of survivors, and this is across various cancer types, reported that they had at least 1 rehabilitation need. Okay? So there is definitely a reason to be referring on to rehabilitative providers that can help. Now, this is from Dietz's work, which was published back in the 1980s. And so this is just a breakdown of how do you classify where therapy should fall. And so what Dietz showed is that therapy can be both preventative, restorative, supportive, or palliative. And so typically in our current medical model, we're in these two middle areas. We normally identify an issue, then you write a PT script, PT takes care of it, and we wait till the next thing pops up. That's kind of how we handle things in the U.S. I'm not going to tell you what my political slant is. All right? But what is coming down the turnpike is this conversation of pre-rehabilitation. Has anyone heard of this term yet? So this is actually being pushed by the ACSM, the American College of Sports Medicine, and also by the physical medicine and rehab docs. This view of how about we start therapy at the beginning. So when they get their diagnosis, and yes, the biggest barrier right now is people are like, but they're dealing with so much. We're not saying start therapy as in you're going to come see me 3 times a week for 4 weeks, but we're going to do your baseline testing. We're going to educate you on what the side effects may be of your various treatments so that there are no surprises, so that you're not calling your nurse 15 times. Because you're like, oh, wait a minute, I felt a tweak over here, or I felt this. All of those things can be handled on the front end. Also, what this particular theory talks about or model is the use of therapy during infusion, which is a new concept. the use of maybe kinesiotaping or exercise during actual infusion to decrease neuropathy. So this is kind of where therapy is moving to, is how can we start introducing it earlier. This is another article that is posted in Medscape, and I'm just posting it here just as a reference for you. The authors did a beautiful job of explaining cancer rehabilitation, and they also went into various types of cancers and talked about different interventions. So this is another public resource out there for you. Now, everyone knows that we are now in that age of everything needs an assessment. Everything needs an objective measure. That's another one of those catchphrases. I'm like, okay, enough. But this is a website that is public access that is called rehabilitationmeasures.com, and it can be used for anyone, nurses, physicians, PTs, OTs, whatever. Because within here is both mobility assessment tools, cognitive behavioral tools, there's even the Braden score for pressure ulcers. And what the particular makers of this website did was they went through multiple assessment tools. They've already captured the metrics regarding reliability and validity and what populations it has been tested in. So you've got a resource to identify tools very quickly. And in most cases, they've pulled in the link to the actual tool. So instead of you having to go through Google and find things, they're all in one place now. So this is a great resource. So in the therapy world, one of the things that we recommend a lot, and this is coming from the ICF model, I think everyone has seen this now, is assessing the whole person. Because one of the things that we have identified in therapy is that not every therapist is open to the fact of treating the oncology patient as a whole person. We are trained to be very impairment-based. And so a lot of times what happens is we will identify defect in range of motion. We will maybe identify that with a decline in transfers or maybe dressing if it's an OT, and that's where it stops. And the reason why I put this up here is because you may have to go back to your facilities and have conversations with your rehab providers about taking it to the participation level or the society level, because every therapist is not trained to do that. We recently did a survey through the American Physical Therapy Association, and only about 10% of PTs recognize themselves as oncology specialists, or the ability to even recognize impairments of the oncology patient, which was quite frightening to us as a profession. So I am telling you that there may have to be some education given from you to the therapists within your institutions. And the best way to do that is through this ICF model. And so I've got about 12 minutes left, and so I just want to walk you through a case that actually came through the Kansas City area. And so this is a patient, 48-year-old, stage 3. You've got all her characteristics here. The thing I want to point out to you is this is someone who works full-time, and her goal was to, after chemotherapy, go back to work in a month. That's kind of what she came into the clinic. She's like, here's my plan, all right? But her job is primarily related to marketing. She's up on her feet for long hours. She's normally on the phone. She likes to golf. She loved to golf once a week, and she loved to swim a couple of times a week. And she's planning on going back to work full-time in a month. And that's sometimes what walks through our door. And she was adamant about it. All right? Now, she had a radical mastectomy. And one of the things that a modified radical resectomy, and one of the things I want to talk about is the range of motion recommendations that are out there. Chen and Chen did a study in 1999 where they compared introduction of range of motion exercises at 6 days and then after drains were removed. And depending on your protocol, that can be up to 2 weeks out. And what they showed was that there was no difference. No difference in range of motion at 3 months out and 6 months out. But what wasn't really publicized a lot from the study, that was shown, was at that 1 month time mark, there actually was a difference between those that were early mobilizers versus later mobilizers. And so now the current recommendations is that you start active range of motion of the shoulder girdle as early as post-op day number 1. And depending on your institution, some people are recommending that that be up to an hour a day. And that can be divided up into 15, 20-minute blocks, whatever your patient can tolerate. The other recommendations is to add in deep breathing, okay? Because what we know is that if someone is in that kind of pain position, so rounded shoulders, forward head, scapulas are protracted, it is very difficult to breathe. So we work a lot with those patients on postural correction, on being able to open up their chest so that they can breathe. And so this particular link that is located here is from the University of California, San Francisco. They get my gold star of the year. This is the most beautiful patient education PDF I've ever seen. Within it, there is pre-operative instructions in regards to exercises, and it was a multidisciplinary tool that was developed. And then they have post-operative instructions, and they break it all the way down to 6 weeks out. And it's beautiful. It's got photos and everything in it. Now, the thing to know is most oftenly what we will do is we will say, okay, we're just going to hand this handout out to everyone. But SONAR in 2008, they did a study and they randomized. They did one group with handouts and one group with handouts and PT, and they showed that the group that got the handouts and PT actually does better. And we kind of know that, is that that one-on-one individualized care always tends to have better outcomes. Now, this is a video. One of the things I tell providers, the best thing you can do is give your patient a balloon. They hate them spirometers. Them blue things, hate them. They hate them. I got a stack of them in my clinic right now. We like make Legos and stuff out of them because they hate them. But one of the best things you can do is give them a balloon. And then what we did later on was we added in some core exercises with this patient, having her legs up on a ball. But just give them a balloon and have them practice inhaling and exhaling. And that is wonderful for breathing exercises. All right. There has been more than enough conversation about chemotherapy, different protocols that are out there, and we're aware of the side effects. One of the things that we use in our clinic is the fact sheets that are located on the NCI website. They're public access, and they're beautiful patient information tools. And this is another opportunity to kind of talk with them about all the different side effects. And a lot of these things can be also addressed through the use of physical therapy or occupational therapy. These are the side effects that are related to hormone therapy. And once again, there are things out there that can be done that are above and beyond just pharmaceutical or medicinal interventions. And the speaker before me, I'm not going to even say anything about radiation because she is the radiation guru, okay? The only thing I am going to say is that Susan G. Coleman has a beautiful fact sheet out there for patients in regards to side effects and possible interventions for those side effects. Because sometimes we forget about the fact that there can be skin changes. There are incidences of nervous issues, so in regards to like numbness, tingling, those kind of things, even weakness, depending on how much radiation they've received and actually the location of the radiation. So we'll always listen to patients when they're reporting those. And so once again, here's that patient that we're going to be talking about. And so using the ICF model, what her impairments were was she had a decline in range of motion, she had muscle weakness, she had lymphedema risk, she, I believe, had 15 nodes removed, and she had fatigue, and she had CIPM. And so her issues in regards to on an individual level, she had difficulties reaching, difficulties lifting, and she would also get dizzy when she would do more than 2 minutes of activity. And remember, her goal is to be back at work for 8 hours. And she still thought she was going to go golf once a week. And then from a society standpoint, she was really concerned about not being able to meet her job demands because her compensation was based on her productivity at work. And she was concerned about being able to fall back into her roles as a mother and also a wife. So the environmental and personal factors are basically things that facilitate or serve as barriers to return to function. And so for her, it was her fear of unemployment. She was obsessing about the fact of not being able to go back to her job, being travel precautions related to her care, to her cancer treatment, her housework. She did not have a plan for housework at all. She was thinking she was going to be able to go back and do all of this. Then she had some body image issues and also anxiety. And so basically what we did in the clinic was we set her up with the psychologist to help her work through some of her anxiety issues, also to do some behavioral retraining, to be able to see herself in a positive light even after her surgery. We connected her with a social worker who was then able to find some financial resources. In the Kansas City area, there is a group that will provide house cleaning services for free, and I'm sure there's something similar in your area, maybe. So she was able to get a housekeeper one time a week. We were also able to find her some resources for child care so that then she could have some respite care for her kids so that she could work. And we were able, one of the things that we do in our clinic that's a little bit different is we actually go to their work site. And if the patient is willing to give us a waiver, we will talk with their supervisor about here's where they're at, this is where we think they can be in a year, and here are the accommodations we would hope you would consider. And so after having a conversation with her supervisor, we were able to negotiate a phased kind of reentry back into her work. So she did 4 hours for the first 3 months and then 6 hours for the next 3 months and worked up. And employers are normally pretty open to that, but it helps to have a rehab professional or even you go talk to them or call them over the phone, because normally if a patient does it, it's not enough. The other thing is lymphatic health. So as you are aware, there is the National Lymphedema Network Society. They have a risk reduction fact sheet out there on their website. Give that to your patients. There's no reason in recreating the wheel. Skin care and the use of prophylactic compression garments. This one is one that has been debated in the literature. But if you've got someone who's complaining of heaviness, tiredness in their limb, what Jane Armour has shown at the University of Missouri is that those women are about 95% accurate that they are having a lymphedema episode. And it's just a matter of them moving from a subclinical to a clinical presentation. So if you're having those conversations with your patients and they're reporting that heaviness, go ahead and get them a garment, a Class 1 garment ordered. And then also you can teach them self-manual lymph drainage. And it's pretty simple. You rub in your neck, 5 to 10 repetitions. Then you go to the other side, 5 to 10 repetitions. This is a student. She was like, really, y'all gonna make me do this? We're like, yes, you're free labor. All right. Then you go in the axillas, pretty much everywhere where there are major node beds. Perfect. And then we teach them what we call the Huck breath. Because what we want them to do is to get a good inhale, because that's where you create that negative pressure at the venous angle, and that is where the lymphatic system dumps into the venous system, and then a really good exhale so that we get exchange. And then they rub right in their inguinal nodes. Okay? And we used to really... The facial expression is priceless. So, because the lymphatic community, we used to recommend like this 10-minute really drawn-out thing, and patients weren't complying with this. 2 minutes of just nodal bed stimulation. We'll have them do it with breakfast, lunch, and dinner, along with deep breathing, and that's enough to increase lymphatic health. This is just an example of a compression bra. And so Mei Fu, who is actually a nurse in New York, is actually doing a study right now looking at the use of the compression bra post-op day number 1. So hopefully her results will be published here in the next year. And then there also are taping strategies that can be used to help soften and make that tissue more pliable and normal too. So these are some of the things that are going on in the clinic. As you are aware, exercise, exercise, exercise. The literature is pretty strong for breast cancer. For the other cancer types, it's evolving. But exercise is a good thing. It's not going to increase their risk of lymphedema. We know that from the literature, and the evidence grade is an A for that. Now, what we do know about exercise is that, particularly for breast cancer patients, they are more likely to have a musculoskeletal injury, and that is probably related to their weakness and poor posture. So that's another reason why they probably need a referral. This is an article that was published talking about how many steps a day. Because what's the recommendation for steps per day? 10,000. This article is beautiful because they're like, most old people and most diseased people are not going to do that. And it's about time that that literature came out. That they're saying that, you know what, that may not be a reasonable recommendation for those populations, but what you can do is find out where their baseline is, and then on a quarterly basis increase that by 500 steps. That is what this article is talking about as a reasonable expectation for your communities, all right, for the populations you care for. So if you have any questions at all, feel free to email me, or if you need a lymphatic drainage video, we're more than happy to send that to you. And thank you very much.